Hello, I'm happy to talk about implementing return to work strategies for both the health and economic welfare of workers with spinal disorders. I'll start with my disclosure statement. Over the past 5 years, I've received various operating grants to support my research, speakers honoraria, as well as my main employment at the University of Alberta and as editor at the Journal of Occupational Rehabilitation. For the next 12 minutes, we're going to talk about work. Work is something that globally we tend to have conflicting attitudes or opinions about. You could even say that we have a love-hate relationship with work. This is illustrated with the following two quotations. Vivian Lee, an Oscar-winning actress, said, "Life is too short to work so hard." While famous inventor Thomas Edison said, "There's no substitute for hard work." Regardless of what side you're on, one major question is whether work is good for your health and well-being. We know that work is often viewed as a reason for either developing or aggravating spinal disorders. In fact, spinal disorders, including neck and low back pain, are leading reasons of work disability worldwide, also leading reasons for lost work productivity. So it's important to know whether there are any health benefits from work. Gordon Waddell and Kim Burton tackled this question in a systematic review published in 2006. They found ample benefits of work. This includes the fact that work is central to our personal identity and social roles. It helps define who we are and our place in the world. Work meets psychosocial needs by providing meaning and a sense of purpose. And very importantly, work provides income. We know that employment and socioeconomic status are primary drivers of gradients in health. Basically, the wealthier you are, the healthier you are, generally. There are also many health risks from long-term unemployment. This includes higher mortality and hospitalization rates, worse overall general health, as well as worse mental health. The long-term unemployed have high distress, anxiety, depression, and more often contemplate suicide. The conclusion to the systematic review was that the beneficial effects of work on both physical and mental health generally outweigh the risks of work and the harmful effects of long-term unemployment. And this is the case even in the sick and disabled, even in those with spinal disorders. So let's talk about spinal disorders. I graduated and started working as a physical therapist in the mid-1990s. It became very apparent to me very quickly that the most common reason for patients coming to see me were pain in the low back and neck. So I treated pain in the low back and neck, assuming that decreasing pain would lead to full recovery and a return to regular activities, including work. Individual characteristics of the workers or the duration of the episode didn't matter as much as the pain relieving modalities and techniques that I used for decreasing pain. It also became quickly apparent to me that this approach didn't work very well for promoting return to work. Patients loved to come to the physical therapy clinic, but often didn't end up returning to work. At about the same time that I started working, there was a study going on in the province of Quebec, Canada, management of work-related low back pain. In this study, therapists were surveyed about their approach to treating workers with low back pain, as well as the goals that were set and the outcomes achieved. One important finding was that just like in my practice, decreasing pain was by far the most common treatment goal. It was a goal over 80% of the time. This was followed by various impairment-based goals. And lastly, there were goals related to improving function. But in only 1 out of 5 patients were goals set related to improving activities of daily living or return to work. Most of the time, return to work was only discussed at time of discharge, and almost never was work discussed at initial assessment. So if those were the treatment goals, what were the outcomes? Well, these patients had very high levels of pain relief success, over 75% success in those with with radiating pain. But the return to work outcomes were very poor. Less than 50% return to work at the end of therapy. We now know that pain relieving treatments relieve pain temporarily, but do not guarantee return to work or functional improvement. If we are to be successful with helping patients return to work, healthcare interventions can't only focus on pain relief, but they need to specifically target return to work. At a minimum, we need to discuss work and help patients set return to work goals. Beyond that, there are some work-focused interventions that can be implemented that have been found effective for improving both health and economic outcomes. The first approach that I'd like to talk about is work-focused stepped care. With this approach, you basically use different treatment approaches at different stages of recovery. This is very different than my early approach of treating every patient the same, regardless of how long they had had their condition. We know that most patients with acute pain will usually recover and return to work rapidly, regardless of the treatment received. Whereas patients with subacute or chronic conditions often require more intensive treatment, things like work-focused rehabilitation. This includes work-related exercise routines, graded activity programs, or work simulation activities. And quite often this is done in a multidisciplinary setting. A stepped care approach was evaluated in Alberta, Canada. This health policy model put limits on the amount of acute physical therapy and chiropractic treatment that workers could receive. No longer were patients receiving pain-relieving treatments for months or years on end. If workers did not recover and return to work within 6 to 8 weeks, they were automatically referred for assessment and then multidisciplinary rehabilitation. We evaluated the implementation of this model and found it resulted in both health and economic benefits. We found that patient satisfaction actually went up. They were more satisfied with the rehabilitation care that they experienced. They also experienced a faster return to work, 5 days on average. While 5 days may not seem huge, since the intervention was implemented across an entire province, the cost savings from lower wage replacement benefits and fewer healthcare visits was quite substantial. We estimated that approximately $21 million Canadian were saved in the first year alone. Another stepped care type approach was the famous Sherbrooke model. Patrick Loisel and colleagues developed and evaluated this. With this approach, different treatments are applied at different stages of recovery, with functional rehabilitation therapy applied in the chronic stage. But very importantly, this model introduced earlier on early workplace integrated care. With this approach, healthcare providers actually leave their clinics and enter the patient's workplace to discuss return to work and negotiate acceptable duties within the patient's functional limitations. This is the basis of participatory ergonomics, where workers, supervisors, and healthcare providers all work together to determine what work modifications are required for workers to be able to return to work safely. Evaluation of the Sherbrooke model again indicated both health and economic benefits. Workers undergoing the full model, which is indicated here in the purple bars, they had more rapid self-reported functional recovery, and they were also more likely to return to work faster. The cost-benefit analysis estimated an approximately $2,000 savings per worker in the first year after implementing the model. Given that this study was done in the late 1990s, when you adjust for inflation, that result is pretty meaningful. The Sherbrooke model was replicated in the Netherlands by Han Anema, who you just heard speak. They found the same promising results. The integrated care approach they implemented resulted in faster return to work despite ongoing chronic low back pain. They concluded that earlier resumption of work activities had no effect on pain intensity, neither positive or negative. Workers could return to work despite ongoing pain. Cost effectiveness evaluation indicated that for every pound invested in integrated care, it returned approximately 26 pounds. A more recent economic evaluation of an integrated care approach was conducted in the Netherlands by Michael Renneman and colleagues. In this study, a 10-hour work module was added on to traditional vocational rehabilitation. This module included development of a return to work plan, along with a workplace visit aimed at resolving barriers and identifying suitable work accommodations. This module led to more rapid return to work, and the cost-benefit analysis estimated that implementing the module resulted in approximately 38% return on investment. I've discussed stepped care and integrated care. Another really promising approach is stratified care with early intervention, With this approach, healthcare providers try to identify patients in the acute stage, so early on in the episode, try to identify who are at risk of developing chronicity. Different treatments are then provided based on risk level, with more intensive interventions reserved for those at high risk. Michael Nicholas and colleagues in Australia evaluated the implementation of a stratified care approach using the Cerebromusculoskeletal Pain Questionnaire. Those patients identified in the study as high risk were referred for psychological assessment and then a comprehensive protocol to address return to work obstacles. Patients identified as low risk received standard care. Evaluation indicated both health and economic benefits. Workers in that high-risk group had better self-report health scores. This included lower pain ratings, less depression and anxiety, less catastrophizing, as well as better pain self-efficacy. On top of that, economic impact per claim was evaluated up to 2 years after implementing the approach. The researchers reported an average savings of nearly 7,000 Australian dollars per worker. To summarize, in this talk, I wanted to highlight the importance of work activity on health and the importance of healthcare strategies that focus on work for people with spinal disorders. I discussed several strategies that have been implemented in various countries. Some of these have even been replicated in different countries, which is very important because interventions can be complex. These approaches, these models, sometimes they're complicated. They involve things like collaboration across several stakeholders, including workplaces. Implementation sometimes requires adjustment of the interventions to adapt them to the local settings and situations where they're being applied. But I want to emphasize that this can be done and it can be done successfully. That concludes my presentation. Thank you for your attention.